So, without wasting much time, I will be talking about a clinical case of heart failure and CKD in a patient of diabetes. So, the learning objective should be to stage heart failure and CKD correctly, prioritize therapies that improve survival and slow CKD progression, select glucose lowering drugs by EGFR, albumin, and heart failure phenotype, sequence goal directed medical therapy safely in CKD, and build a monitoring plan. So this is a 62-year-old male, 15 years of diabetes. He has NYHA grade 3 dyspnea, that is dyspnea on routine activities, ankle swelling, known CKD and albuminuria, hypertension, dyslipidemia, no prior MI, smoker occasionally, is ex-smoker, and overweight, positive family history, and his CKD was EGFR 45 1 year back. The blood sugars were ranging from 7 to 8 to 8.5 in the last 1 year, and with 2 episodes of hypoglycemia. And he is on high salt diet, intermittent NSAID used for back pain. Medicines you can see metformin 2 gram daily, glimepiride 4 milligram daily, glargine 26 units daily, telmisartan 80 milligram daily, amlodipine 10 milligram daily, furosemide he started by himself because of edema since 3 days, and atorvastatin 40 milligram daily. He is on hypertensive side with tachycardia, tachypnea, saturation 94%, and he has all the signs of heart failure basically. There are no signs of infection, and diabetic neuropathy is present. You can see his present labs: HbA1c 8.2, creatinine 2, EGFR 32, urine albumin creatinine ratio of 620, potassium 5.1, Hb 10.8 with iron deficiency, LDL 92, triglyceride 201, ECG sinus tachycardia LVH, pulmonary congestion, cardiomegaly on chest X-ray, and T-proBNP elevated 3200, LVEF 32%, dilated LV. So he is in heart failure with reduced ejection fraction, renal ultrasound, normal size kidneys, no obstruction. Now how we will take up this case? For CKD we will go by the paradigm CGA. C is for cause of the CKD. In type 1 generally hyperglycemia is the cause of CKD, but in type 2 it is a multifactorial disease, and here hyperglycemia, dyslipidemia and hypertension may be contributing factor. The EGFR category, here he falls into the G3B category because the EGFR is 32. Albuminuria category is A3. So basically obviously is a high risk candidate, also has heart failure with reduced function and likely stage C heart failure, that is symptomatic heart failure with structural heart disease, and he has long standing diabetes. So priority here shifts from managing the sugars, that is a HbA1c approach, only to cardiovascular protection and safe glycemia. So these are the various questions. I will just skip the questions because of shortage of time. But this diabetes is a common and rising global epidemic. CKD and heart failure frequently coexist. Albuminuria and low EGFR predict heart failure hospitalization and mortality. Therapies now improve outcomes across organ systems. Clinical consequences: the patient will have polypharmacy with competing targets, and therefore you must be very clear about the treatment, otherwise errors will be common. You also have to manage as per the volume status of the patient, potassium of the patient, renal functions, and the heart failure status. Hypoglycemia is also very common, and that has to be taken care of. So the goal is to maximize survival and kidney protection and then optimize hyperglycemia. Now he is heart failure with reduced ejection fraction. Already in the previous lectures we have seen what is heart failure with mid-range and heart failure with preserved ejection fraction. Now there is a A to D classification of heart failure. A is structural heart failure, structural heart disease with no signs of heart failure. Stage B is structural heart disease with dyspnea on exertion. Stage C is structural heart disease with dyspnea on routine activities, and stage D is structural heart disease with refractory heart failure. And here a patient has long-standing CKD and albuminuria is there. So the structured checklist in this patient would be to confirm the heart failure phenotype, CKD workup meticulously, medication review. Here the patient, we have to take the patient off the NSAIDs, we have to avoid contracts, nephrotoxic drugs, and avoid hypoglycemia prone agents, and alternative medicine drugs also have to be carefully inquired because a lot of patients are taking Ayurvedic and herbal medications, and we have to go for proper labs at the baseline where bicarb electrolytes and bicarb is very important. Screen comorbidities. Here patient has ASVD, atrial fibrillation, OSA, anemia, mineral bone disease. Vaccination also has to be advised and lifestyle modification to be advised. Now you can see that this is the staging of risk in patients of CKD. Not only the EGFR but also the level of albuminuria will decide the risk status of the patient. Target setting, we cannot go for the HbA1c target of less than 7 because we can land up with critical hyperglycemias and frequent episodes. So here the proper target we should consider is achieving a target of 78% without causing hypoglycemia, and we have to use SMEG or CGM in this patient so that the hyperglycemia is less, and prioritize drugs like SGLT2 inhibitors, GLP-1 receptor agonist, RAS, MRA, ARNI, etc. to basically achieve a proper results in this patient, and consider time in range goals when CGM is available. So start with therapies that reduce death, heart failure admissions and slow CKD progression. Prefer agents with neutral beneficial heart failure profile. You have to avoid thiazolidines, avoid certain DPP-4 inhibitors like saxagliptin and alogliptin, accept a small creatinine up to 30% increase after starting ARNI or SGLT2 inhibitors, but ultimately the creatine comes down and levels off. Watch potassium with the use of ARNI, RAS inhibitors, MRAs and finerenone, and de-prescribe hypoglycemia-prone drugs like insulin's dose can be reduced or can be de-prescribed, or sulfonylureas or glycinates. Build a monitoring calendar before you start the this thing. So stepwise algorithm will be to confirm the staging of heart failure, find the CKD cause, see the EGFR, see the albuminuria levels and see the hypoglycemia levels. You stabilize the heart failure because that is a very urgent necessity. Stop the offending drugs like NSAIDs. Start with the foundation drugs for heart failure like SGLT inhibitors, ARNI, RAS inhibitors and evidence-based beta blockers. Add on MRAs and here eplerenone and finerenone with the better drug. Finerenone is the preferred drug if the EGFR is more than 25, which is the case here. And GLP-1 receptor agonist also is a good drug to use in this situation. And we also have to give iron, parenteral iron. Basically, it will improve the CKD and heart failure both. So, to stabilize heart failure congestion, we have to assess the priorities. Loop diuretics initially, loop diuretics to improve the congestion part, and then we can transition to eplerenone or finerenone. Hold nephrotoxic drugs. Check the potassium and creatinine because with potassium on the higher side, we have to bring it to normal levels before we start the ARNI or RAS inhibitors or finerenone, and treat the triggers for heart failure like ischemia, infection, arrhythmias, and uncontrolled diabetes, uncontrolled blood pressure. A note of caution that if you go on giving diuretics in higher doses, patient will end up with AKI. You have to down titrate the loop diuretics. Once the U volume is achieved, if there is a resistance to torsemide or furosemide, you can add thiazide-like diuretics. Metazolone is the preferred choice here, and you have to replace potassium, magnesium, and avoid overdialysis. After decongestion, start or up titrate goal-directed medical therapy appropriately. SGLT2 inhibitors, both DAPA and EMPA, are approved in EGFR more than 20. Beta blockers, evidence-based are bisoprolol, carvedilol, metoprolol. ARNI preferred in heart failure with reduced infection. Otherwise, we can give RAS inhibitors. MRA is basically eplerenone, and because the patient here has CKD, then finerenone would be preferred ahead of eplerenone after the U volume is achieved. Core pillars for CKD: RAS inhibitors, SGLT2 inhibitors, BP and sodium control, statin therapy, lifestyle modifications, and if the sugars are not still controlled, then GLP-1 receptor agonist, and there are a lot of trials to substantiate this. Who benefits from finerenone? Type 2 diabetes with CKD, EGFR typically more than 25, they should have potassium less than 5 to start with, and recent data shows that in patients of heart failure with preserved infection or heart failure with mid-range injection infection, finerenone offers significant CVD benefits. That is the latest thing in basically, so it is the drug of choice, the diuretic of choice in this patient of high diabetes with CKD and heart failure. So GLP receptor agonist can be given till the end stage renal disease. They have great benefits on the ASCVD risk reduction, especially stroke basically. But in advanced CKD, the patients may not be able to take well, and as GLP-1 may compound the problem. So we have to use these drugs with caution in patients of advanced CKD. Otherwise, they are very good drugs to use. And the glucose lowering drugs, the dose has to be modified as per the eGFR status. I will not go into detail because of the time constraints. Hypoglycemia prevention should be there. You should use those agents which are having least hypoglycemia. Sulfonylureas should be down titrated. Glimepiride and gliclazide can be used in lower dosage if you want to have, if the sugars are on the higher side. And glipizide basically is predominantly excreted by the liver, and it also can be used. Basal insulin should be used. The bolus insulin should be reduced because the insulin secretion is predominantly by the kidneys basically. Now red flags in heart failure, thiazolidines to be strictly avoided, some DPP-4 inhibitors, sexagliptin, alopetin to be avoided, over-aggressive insulin repetition to be avoided, sulfonylureas also to be down titrated to the minimum levels required. Preferred drugs are the SGLT2 inhibitors, GLP receptors, and linacliptin in the DPP-4 class. Blood pressure target should be less than 130/80 or less than 120 systolic, wherever it can be achieved safely basically. But we should avoid hypertension, use home BP and standardized office methods for monitoring the blood pressure. The drugs of choice here would be ARNI and followed by ACE inhibitors or ARBs. If the blood pressure is not still controlled, then dihydropyridine CCBs like amlodipine should be used. Do not combine ACE inhibitors plus ARBs plus DRIs because or ARNI because they can harm. Use one of them, and you have to monitor the electrolytes. So hyperglycemia, if the hyperglycemia is there, take off the offending drugs like the NSAIDs, Bactrim, ARNI, and the RAS blockers also can be reduced or omitted for the time being. Give potassium binders to bring the potassium to the normal levels. And the Localma is the new drug basically which inhibits the absorption of potassium from the GIT and can be used. And once the potassium comes in control, then you can use these drugs. So you assess the patient, escalate loop diuretics in a diuretic resistant CKD, and add synergy drugs like metazolone. And if still congested, then you have to go for dialysis to create negative balance. Anemia to be treated with parenteral line therapy, and metabolic acidosis also to be aptly treated basically. Otherwise, you will not get the proper results. Sick day rules: you have to teach the patient sick day rules for AKI prevention for control of diabetes once they are sick basically. And here they have to monitor their hydration status and the sugars and the ketosis so that the patient does not get complicated. In advanced CKD, that is eGFR less than 20, metformin to be discontinued, SGLT generally not indicated, but you can continue till patient goes on dialysis. If it is already going on, insulin needs fall, Finerenone should not be used below 25, and you should use other loop diuretics. So medication changes here. In the case we discussed, we stop glimepiride, NSAIDs, high salt substitutes, modify metformin to keep it at 1 gram per day, simplify insulin, add heart failure drugs, SGLT2 inhibitors. We switched from ARBs to ARNI, and we added Finerenone diuretics, initially loop diuretics to achieve euvolemia, and then we omitted it because Finerenone is going on. We did not start with eplerenone, and we monitored the potassium creatinine 1 to 2 weeks, and then after a month, and then every 3 months. Target was to achieve euvolemia and UACR reduction and HbA1c of 7 to 8. Vaccination to prevent the complications because of the infections, nutrition and exercise rehab plan, and follow-up was 2 weeks, 6 weeks, and every 3 weeks. The other cases also I will not go into this detail because of the. So this is the last slide. We have to have a ward checklist to manage these patients, and we have to plan out the proper plan of action, titrate the drugs as per the clinical status of patients, do the investigations properly at proper timings, and chart out a follow-up plan to manage these patients well. Thank you very much.
Thank you, Akash, for the lucid and nice talk. And any questions from the Anil Kushal sir, any questions, sir?
वो तो लाइफस्टाइल में आ गया ना, लाइफस्टाइल इसमें इतना कितना 15 मिनट में तो सो आई विल हाँ
Earlier time, every heart patient was tendency, but now it is obese. What is your opinion?
नहीं earlier heart failure patients there is nothing कि heart failures are now getting obese. Obesity is in general increasing, and it is postulated that by 2035 50% of the world population will be obese, overweight or obese. So it is in general observation, and in